Welcome everyone to the SSR resident lecture series here, and just want to thank everyone here for coming online. And we have a special guest here today. I would like to first just introduce myself. My name is Jonathan Samet. I'm at Lurie Children's Hospital in Chicago as part of Northwestern Hospital, and we have an awesome speaker, Dr. Nguyen here. She is a pediatric MSK radiologist with dual fellowship training in both pediatric and MSK radiology. She is currently the director for the section of MSK imaging at the Children's Hospital Philadelphia. Her clinical interests include imaging of bone tumors, maturity-dependent pattern of injury, and osteoarticular infections. Her research interests include radiation-free bone imaging using UTE MRI and quantitative assessment of tissue quality using MRI and ultrasound. So we look forward to your talk, Dr. Nguyen. Thank you so much.
Thank you so much for the kind introduction. Awesome. Well, thank you, everyone, and thank you for spending your lovely evening with me. So my talk is described as imaging of normal and abnormal growth plates. No financial disclosures relating to this subject matter. So I actually have a question to start everyone off with. So this is the first case I had when I was a first year attending. The chief of orthopedics at Wisconsin came down and was like, what do you think happened here? So this is a 2-year-old male, adopted, so they have no history, who is developing this mild genu varus deformity of the right knee, but the contralateral side looks fine. So this is where you guys get to log in and highlight where you think it's abnormal. I can hide other people's answers. So, wow, we got more responses. Okay, let me hide. And we'll wait maybe about 20 seconds and see where people are. So essentially we have AP view of the knee. I'm kind of zoomed in here in the distal femur and proximal tibia with a little bit of the fibula sticking out there. Very cut in, so I'm sorry, I'm not showing you the soft tissue planes or showing the contralateral side. Let's see where the responses are. Oh, wow, you guys are really good. So we're gonna kind of split hairs a little bit and look a little bit deeper into this area, because I know some of you guys are hovering over here. Other of you guys are hovering up there. So is it the epiphysis? Is it the actual growth plate, or is it actually sticking into the metaphysis? So the next modality that we typically use for imaging children is not CT, but MR. So here's the MRI. And now I have a new question for you. Coronal MR images of the knee. Well, this deformity that we saw in radiograph, which was shown here, you guys nicely identified, will this still grow? So the kid is 2, right? He still has at least a decade to grow. So your choices are A, yes, B, no, and C, not sure. I'm actually hiding everyone's responses. So I have a fat image on the left and a fluid sensitive image on the right. I'm showing you this area of deformity. I'm going to talk about what each structures mean. See where you guys are. Oh, very good. Okay, so most of you guys got it right. So it will grow, but how much would it grow? So hopefully for the rest of the presentation, you will know what to look for and also what to put in your reports. Okay, so the objective of this presentation is to review the anatomy of the growth plate, discuss normal growth and patterns for growth disturbance, such as the case just shown. And we'll also talk about key principles that guide clinical decision-making. So the outline, first, we'll talk about growth plate anatomy and function. Then we'll cover imaging findings of direct injury. So when we think about growth plate injury, we always think about the growth plate proper, but I'm also going to focus your attention on indirect injury, where you injure the epiphysis or the metaphysis and it's blood supply, and therefore indirectly you see findings are abnormal relating to the growth plate. And then finally, management, how much you can spend all day describing, right? But what is actually important for clinical decision-making and the part that your surgeons actually really want to know. So starting with anatomy and function. So bone formation, there's two general types of bone formation in the body. The intramembranous ossification, which is responsible for putting bone on a flat cartilaginous framework. And that's what you see in the calvarium and the pelvic bone. But what we're going to focus on is endochondral ossification, and that's what happens at the end of long bones. So another poll question. So how many growth plates do you see in the distal femur? So I'm not asking the whole image or the ones that you potentially would see if you go to another image, but how many would you see just in the distal femur? I've shown here. So A is none. Oh, sorry, let me hide. A is no growth plate, you're tricking me. B is 1, C is 2, D is 5, and E is just too many. So I have a fluid sensitive image in a very young child, and we see a little bit of knee joint fusion, just ignore that. And we see a little bit of the cartilaginous patella and the femur and the tibia. Okay, let's see. The results are still coming in. We have 14 results so far. Let's see. Oh, you guys are good. So most of the time in the reading station, when we're talking about growth plate, people always think about the primary growth plate. So in the distal femur, there's actually 2 growth plates. So 53% of you guys are really, really good. So, oh, someone changed their mind. Okay, so let's go through. So we have the primary growth plate right here, which is also known as the discoid. It's responsible for longitudinal growth of the bone itself. So the femur in this case. And then we have the secondary growth plate, which is the same format except slightly smaller. And that's what we call the spherical growth plate. And that's responsible for enlargement of the secondary ossification center. These are seen in the epiphyses and apophyses. And you can see that there is actually one there in the tibia. The carpal and tarsal bones, as well as the sesamoids. So the growth plate can be seen on radiograph as well as MRI. Right? We always start screening with radiograph, and because the growth plate is cartilaginous, we only see a void in that area. On MR, we typically rely on T1 or PD weighted images, and then fluid sensitive images, T2 weighted or PD weighted fat saturated images as shown here. So on T1 weighted images, we can see the growth plate following signal of the growth plate here. But on T2 weighted images, even though it is hyaline cartilage, it's slightly different than the adjacent unossified cartilage. So that's why we like the fluid sensitive images. And when we zoom in a lot, especially with our kind of better magnets and higher spatial resolution, we see this Oreo cookie or the reverse Oreo cookie, this trilaminar appearance that people talk about. And it's hard to know exactly which one is a growth plate. And I'm going to tell you that this one that's closer to the epiphysis is the growth plate proper. This little wavy line that's dark on all pulse sequences is the zone of provisional calcification. And then this other line that we now kind of see in our newer scanners quite often is watery new bone. So this is actually getting into the metaphysis and just baby bone that's very watery. So we're going to dive even deeper in the cellular level and look at the growth plate. So the growth plate here shown, not drawn in scale, is moving, the cells are moving from the epiphyseal direction toward the metaphyseal direction. And that pushes growth in the opposite direction. And the cells within the growth plate is organized in a zonal fashion. You have the reserve cell at the top, what's randomly distributed. It stores nutrients, and it actually receives blood supply from the epiphysis, which we'll talk about in a little bit. The proliferative zone, which is responsible for really pushing that growth plate out, right? Essentially elongating the bone. And in the hypertrophic zone, where the chondrocyte undergo programmed cell death, also known as apoptosis, the matrix become calcified, it forms that zone of provisional calcification, and then those chondrocyte gets removed. In the periphery of the growth plate, you have what's called perichondrium. It surrounds the growth plate. It contains a groove of Ranvier, which is responsible for transverse growth of the growth plate, and then the ring of Relax for mechanical support. And this is a structure that when you have, like, let's say, metaphyseal osteomyelitis and you have subperiosteal elevation, that prevents it from extending all the way over to the epiphysis. So it serves as a barrier. So moving on to the epiphysis. So in the epiphysis in children who are skeletally immature, you have not only the articular cartilage, which is avascular, but also the unossified epiphyseal cartilage, which is right underneath. And then you have the secondary ossification center, the SOC. Note that there's the growth plate surrounding the secondary ossification center, just like the primary growth plate, right? Just slightly smaller. And over time, that will it will continue to grow to replace the unossified epiphyseal cartilage. What's important is that you can see these little tiny vessels extending into the growth plate. So it keeps this area of the growth plate, which is right adjacent to the epiphysis, nourished. So here are 3 different patients at 3 different ages. You can see the secondary ossification center, denoted by the star, continues to get bigger to replace an unossified cartilage, so that at skeletal maturity, all you have is the articular cartilage. In the metaphysis, you have vascular stasis. You have these end loops that prevents any blood or any nutrition from migrating into the growth plate. So it wants to starve the growth plate so the cells will undergo apoptosis. In the metaphysis, it also undergoes internal remodeling, meaning that those dead chondrocytes are removed so that bone can be deposited. And then also you have this funneling. It's done by external remodeling. So just to review the growth plate complex. So we have the chondrocytes lining up in their nice little columns. We have the epiphyseal vessels that nourish the chondrocytes. And then we have the metaphyseal vessels that are really mean and want to starve the chondrocytes. So it generates this area of a zone of avascular zone to induce apoptosis of the chondrocytes. Okay, so the next part, we're going to review different injury to the growth plate proper and injury to the structure, the vasculature adjacent to the growth plate. So in direct injury, for example, a fracture here, it allows communication of vasculature between the epiphysis and metaphysis. And that allows recruitment of osteoprogenitor cells, right? Osteo meaning that they're actually forming bone. So when you have injury directly to the physis, it recruits these cells, and over time, it will form that transphyseal bony bar. Okay, another poll question for the audience. I have a 13-year-old female who presents for assessment because she just thought her wrist looks a bit asymmetric. So where is the abnormality? And in peds, we love getting that contralateral sign. It doesn't mean that you have to get all 3 views or all 2 views, but you can just get that one view where you really kind of question that abnormality. So, and this is somewhat a trick question. I guess there's multiple answers. We'll give it a couple more seconds. So we have very coned down views of the wrist bilaterally lined up here. And sometimes the patients are really good and give us a really good history, but most of the time they're like, I don't know, I fall all the time, or I play sports, it hurt a little bit, it went away. So occasionally they come in and you're like, wow, that must be some injury you had and you never came in. So, okay, let's see. Oh my gosh, you guys are so good. And the satisfaction of search, right? There's actually a little fracture right here, which no one cares about. And then you can also question, is this a little bit widened? It's nice that you have that comparison from side to side. So very good, you guys. So when skeletally immature patients suffer a fracture, 18 to 30% involves the growth plate, right? Because they have growth plates everywhere. Of those that involves the growth plate, only 5 to 10% results in a growth disturbance. Of course, it happens more with boys than girls. Happens more commonly during growth spurts, which is postulated to be due to transient bone frigidity because the structure, the scaffold is growing, but the mineralization, right? The bone is not strong enough to withstand the force, even though it's growing so fast. And then the increased ability to generate force, more muscle mass. And then also the perichondral sleeve, right? The thing that holds it together is the one that's actually involuting at that time. So this is a GRE image, which really puts the bone really dark so that you can highlight the cartilage. Doesn't give you much other anatomic information, but it really helps us in this particular case to estimate how much of the growth plate is being lost. You can see that we're losing that cartilage signal across the mid portion of the distal radial metaphysis. So in the acute setting, if the patient actually came in rather than waiting and coming in later, in the report, we want you to use the term Salter-Hers classification because that term is widely used not by radiologists, but also by orthopedic surgeons. It's just easy because everyone knows what components are involved. However, one thing that you should know that even though you theoretically initially when it was devised for this classification, that it's supposed to be higher energy with higher grades of Salter-Hers, but it actually is not. And so it doesn't predict outcome, even though we still use it just because everyone understands what you're talking about when you say Salter-Hers type 2. So let's look at a few of the examples. So here is a patient, the ring finger. You can see that there's a fracture through the physis, and there's actually a little angulation and rotation of the distal involving the distal phalanx. So this is a different patient. You can see that the fracture cleavage plane went through the physis of the thumb proximal phalanx and then exit out through the metaphysis. So a Salter-Hers type 2 involves the physis and then also the metaphysis, versus a Salter-Hers type 3 enters the physis, but then exits intra-articularly into the epiphysis and into the joint. And then a Salter-Hers type 4, unfortunately, does not occur that often in the finger, but happens quite often in the ankle. So I'm showing you a distal tibial fracture here that involves both the metaphysis, traverses the physis, and into the epiphysis and into the joint. Type 5 is a bit debated. We don't use that clinically as much. It's believed to be due to crush injury, and usually in the acute setting, you can't really tell that injury is there on radiograph. But you see the delay sequelae. And so in the acute setting, we tend not to throw out that term, oh, it's probably Salter-Hers type 5. Typically, we just say Salter-Hers type 1 or predominant physeal injury. But one thing to note is that usually the ones that extend into the joint, right, especially the bigger joint, as I showed in that last case with the ankle, but also in the knee or the elbow, anything that extend into the joint, the surgeons want to know, is there a step off or is there a gap? And so they will be getting CTs on these patients, and they're looking for those two components in your report. Okay, so moving a little bit past that, we have a fracture, it's been reduced. We can see a cast over it. So this is a 14-year-old male status post reduction of distal tibial Salter-Hers type 2 fracture. So what do you tell the on-call orthopedic surgeon? And now it's actually midnight and you're on call by yourself in the hospital. Your choices are A, beautiful anatomic alignment, B, yet another post-op with cast, obscure visualization, but not too bad from what I can see. And then C, what do you think? How do you think it went? And then D, shouldn't you take this kid back to the OR? Oh my gosh. C, we'll show the instructions and wait for the responses to come in so you're not biased by other members' responses. So at CHOP now we actually have faculty coverage. So our trainees are never alone. But when I trained at University of Wisconsin for my residency, and it was a great program, we were alone, and it was actually really nice to be able to make these calls, but it definitely is hard because you don't know what to say, right? And I feel like most of the time I'm asking, hinting, do you think you had a good reduction? So these are difficult and these are really hard because what you say will last for the next 8 hours before the attending comes in the morning, right? So we have 14 brave souls who have selected some choices here. Any last minute choices for anyone before we show the responses and review the case? One more. Okay, so let's look at the responses. Oh, you guys are so good. Shouldn't you take this kid back to the OR? Why? No, this is great. So the reason is, so the main purpose of reduction, right, whether the ED physician does it or they actually go to the OR, is for anatomic alignment, which I think this one is pretty good. It sucks that the cast is over it. You can barely see the fracture, but you know, it's there. But residual physeal widening is one component that you should always have high index of suspicion. And for these, you can see anteriorly it's widened. For these, they may require surgical reduction, and that usually needs to be done within the first half a week, just because these patients, younger patients, right, with abundant healing response, that by a week into their fracture, like they essentially have to break the bone in order to realign it or take out any interpositioned soft tissue. So most commonly, it's the periosteum that gets embedded in the fracture. Occasionally, there's public reports of ligaments, tendons, muscle, even neurovascular bundle. For this particular patient, luckily underwent MRI. I guess it was a quiet night. You can see the torn periosteum right here. So it is a metaphyseal periosteum up here that got torn, and the fracture, right, opens up, this falls in, and then it bounces back as if the alignment looks really good, but this piece is inside. And the periosteum has propensity to form bone, right? That's what it's supposed to do when you have a regular fracture. So this will be concerning that it will form a bony bar. So there's a really nice paper that looked at compared the widening and had a cutoff of 3 millimeter. So a widening of more than 3 millimeter has 60% risk of premature closure, as opposed to no less than 3 millimeter, which is 17%. So some, no matter what you do, will go on and have transphyseal bar. This is the same patient 1 year later, and we have both sides in the bore. So we took some images from the other side as well. You can see that there is a bar right in here, and then there's asymmetric appearance of the epiphysis, right? And that's because in the height where the growth plate is different, is because there's differential growth. Even thought anteriorly where we see the most widening, it's not closed, but it's sick. So it's not growing as much, and therefore it's not pushing the metaphysis out as far as the posterior where it's not disturbed and completely normal. Okay, very good, you guys. Okay, so indirect injury, and now we're going to look at epiphyseal indirect injury and then followed by metaphyseal indirect injury. So going back to our little cartoon here. So if you affect the epiphysis, right, you're removing that nourishing blood to the chondrocytes. Then you end up having this deformed abnormal secondary ossification center, and the chondrocyte just can't really work, right, when it's not being nourished. And so you end up having the chondrocytes not pushing that metaphyseal margin as far. And so over time, the normal site overgrows. So it looks like it's receding into the metaphysis. And then if you wait long enough, then it will completely close, because after a while, the chondrocyte just run out of energy. So here is a 3-year-old boy with left-sided limp. And this is actually a really, really hard case. I almost was going to put it in the poll, but I ended up not doing it just because on a really good day with a lot of coffee, a zoomed in image, then I think it's callable, but it is really difficult. So the kid is young, right? And your differential in these younger patients, you're thinking, could it be avascular necrosis, Perelman? A little bit too young for SCFE, right? So I can tell you that this growth, the secondary ossification center here, looks a little bit more bumpy, a little bit more loosened, especially in that lateral aspect, but it's a really hard call. So there was very high clinical concern. And so the patient underwent MRI. And remember, for the MRI, I know we're cutting down on contrast, but this is the one indication where if you don't see anything on the non-contrast images, still give contrast, because of very, very, very early Physis, it may look relatively normal. Just because there's abundance of red marrow, you can have that kind of intrinsic higher signal on the fluid sensitive image. So you do want to see that post-contrast image, which is shown on the bottom here. You can see that there's no enhancement of the secondary ossification center. So Perthes disease. So the arterial blood supply to the head is by the medial circumflex artery. In kids who are younger than 3, there's actually dual supply by the lateral circumflex. And for those who are a little bit older, more than 8 to 10 years of age, there's a little vessel in the ligament teres that help to supply the ossification center. But between 3 to 8 is a time when they're actually relatively weak. We don't really know the exact pathophysiology of Perthes disease. It may be a combination genetic predisposition, microtrauma, but they tend to cluster in these younger patients just because they are already vulnerable because they're only supplied by one artery. Okay, so this is the same patient 5 years later, and you can see that we're now actually at this stage, right? We can still see the irregular growth plate, some of it kind of extending in. This is probably a more relatively normal area versus the other area, which is really abnormal and sick. You have flattening of the femoral head, and now it's deformed and it's actually hanging out from the acetabulum. You have remodeling of the metaphysis where you have that coxa magna deformity. And so this is really concerning. And usually the surgeons want to know how much of it is hanging out, right? When you start losing that congruity, it's hard to contain the head in. And these are really hard because even when they go in and intervene, that they try to bring in blood supply by drilling from the metaphysis toward the head. Some kids do well and some kids don't, and it's really hard to tell. In contrast, this other patient who is a 5-year-old boy who had neonatal meningococcal infection and began to develop this varus alignment of the right ankle. Again, we have both ankles for comparison. You can see that this is elevated right in here, right? It's hard to see the growth plate through here. So you're wondering, is it completely closed? And therefore, we're in that last stage, right? Pretty late. And then also look, the talus is kind of remodeling across as well. So overall, not very good because now everything else is compensating for this deformity. So moving on to indirect injury from the metaphyseal side. So if you remove the apoptotic signal, right, then the chondrocytes doesn't have that signal to undergo apoptosis. And so even some of them may hang around, some may undergo apoptosis, but they're not being removed. So you don't have that remodeling from that first layer of metaphysis. And so that gives the appearance, if it's focal, a focal tongue right here, sticking out here, or a broad band, if it's more diffuse. Okay, so now I have a 5-year-old female, status post chemotherapy for leukemia, presenting with ankle pain. And what is this? And I'll point to it right here. This little area, right in this region. So we have a single view of the ankle in a skeletally immature patient. There's no fracture. This finding is not that common, but when you do see it, it is stereotypical. And you can see that there's suggestion of a growth arrest line right here, meaning that at that time when this line was here at the growth plate, there's some systemic stress for the bone to not move as much, and therefore more bone was deposited. So it generates this growth recovery line. It is parallel and actually abuts this area that's loosened. We have 13 responses thus far. So choices are leukemic infiltrate, osteomyelitis, growth plate cartilage, or intraosseous lipoma. It's probably there all along, we just never imaged the ankle. Okay, let's look at the responses. Oh, good, growth plate cartilage. Okay, so leukemic infiltrate tend not to have this kind of very contained or even lytic process. Usually it's something that we see on MR, but not much on the radiograph, because you need to lose at least 30 to 50% of the bone stock in order to be visible on radiograph. Osteomyelitis is definitely possible, especially when these patients undergo avascular necrosis. They're vulnerable, right? So, but growth plate cartilage, because it actually abuts the cartilage, right? It has the same lucency as the cartilage. And so the next imaging modality, you guys will all say MRI. So, okay, here are the MRI images. And I just want to say that this case was courtesy of Dr. Carl Mello from Cincinnati Children's. And this is a beautiful image that they imaged, showing a fluid sensitive and then a T1 weighted image, a coronal and a sagittal. And you can see that this area that was loosened on the radiograph, right, follows the signal intensity of cartilage in both pulse sequences. You can see that this also abuts this area of avascular necrosis, a serpiginous abnormal signal intensity in the metaphysis. So this is essentially you're losing the metaphyseal signal, and the chondrocytes just kind of hang around. And this will be an example of a focal tongue. So here I have a 13-year-old boy picture, and he's having a little bit of shoulder pain, you know, on and off. And you're like, oh my gosh. So for these patients, it's pretty classic if they do the exam and they push at the level of the physis, the sports medicine physician, and they have pain, then they know that they probably have low leak or shoulder. Most of the time they end up skipping the radiograph and just go to the MR because they want to know how severe and how active the injury is. So this is usually acute on chronic. It tends to be right here. There's widening of the physis. You can see that there's irregularity and loss of the zone provisional calcification because the body just cannot keep up. You see diffuse, you see more focal widening of the physis laterally, but it can progress to be diffuse if it's more severe. And there can be reactive marrow edema. And I think MRI is very helpful when you see that edema, that you know it's more active and acute, and they should be shut down fairly quickly. Here is a female gymnast, so very similar, right? Overuse injury. You can see that there's irregular widening of the physis, kind of receding of that zone provisional calcification that seems disrupted. And then maybe so a little bit in the distal ulna. So for these gymnasts, right, they're walking on their hands, on their wrist. Injury to the radius is most common because that's where how you transmit the load to the carpus. And so in a very mild form, you see abnormality only on the volar aspect, and then can progress to be diffused. Ulna tends to be involved in a minority up to 20%. And early injury is reversible, but late injury, if they continue to perform and not, not rest, it can cause physeal injury and cause irreversible growth arrest. So for this patient who actually complied, it's really hard to tell an athlete to stop doing what they're really want to do. That actually completely reversed, right? It looks beautiful. So, okay. So moving on to the last part, the management. So what do you need to put in your report? So in order to know what to put in your report, you have to think like a surgeon. Think about biomechanics, think about, how is the kid growing and what information they need. So treatment is individualized. It depends on the anatomic location, the anticipated growth, as well as deformity, and we'll go through each of these. The anatomic location, right? If it's lower extremity, it's much more important because you walk on it versus slight asymmetry in the upper extremity. And then also each growth plate does not have the same growth potential. And this is a really nice picture that was generated by Dr. Haley Allen, who was a resident in Wisconsin and now at University of Utah Health. And you can see that the proximal, if we take the humerus, the proximal humerus contribute 80% to the length of that bone versus the distal humerus. That's why you see so many of the post-operative images on supracondylar fractures where they need to be very precise and very perfect, just because that area doesn't grow that much and therefore does not remodel as much to make it more normal. Versus the proximal humerus, it does remodel quite a bit. The same orthopedic surgeon from my first year told me the best way to remember this is if you imagine someone sitting in a bathtub with a cup of beer. So your wrist is above water because you have to make sure your beer does not go into your bathtub. And then your knee, your shoulder is above water, right? Because you're sitting up and you're not like sliding down into that tub. And your knee is bent. And so therefore your distal femur and proximal tibia is above water. So anything that's above water contributes more to the overall growth of their respective bone compared to those that are underwater. So now with that information, I have probably one of my last poll questions. 9-year-old female with humerus fracture, should it be repaired? So your option one, I know my responses are getting longer. Oh, well, too late now. We'll probably need future surgery to correct alignment because I already see healing response. B, no need to worry. The body will marvelously take care of itself. C, these outside hospital people never know what they're doing. OR, stat, to realign. And then D, choice is not mine. I'm just a radiologist. That's why I leave it to the surgeon. So I have a attempted axillary view of the shoulder. You can see there's a fracture in a skeletally immature patient that involved the proximal humerus. On this particular view, it's kind of hard to tell whether it actually goes into the physis, but since the physis is relatively weaker, it probably, to some extent, went from metaphysis into the physis or physis into the metaphysis. We have a few responses. Others are still thinking. So much to read for the choices. I apologize. Okay, let's see what you guys said. Oh, no worries. The body will cure itself. So that's great. That's exactly what I would do. So this is the same patient a year later. You can see that it actually remodeled. That's because on the previous slide, I showed that 80% of the growth of the humerus come from the proximal end. So even that it looks really bad, you're like, oh, why didn't they take them to the OR? It looks so bad. It will remodel, and it will, a couple of years later, you'll be like, oh, didn't even know it happened. So the other component is anticipated growth, and that depends on age and sex. So I'm showing you two patients, 2 feet, from a male and a female on the right. Oh, I'm so sorry. You can see that the male on the left is 13-year-old, almost 13, but still have a lot of open growth plate, versus the female on the right has mostly closed, right? So you have to know how much growth do they have. If they're completely skeletal mature, then you need osteotomy. So you can't really do guided growth. So knowing how much growth and how young their skeleton is very helpful. The other component is, after the injury, is the physis still closed? Is it still open or closed? And so the 3 example we had was, right, it's reversible. You can have a trial of rest. And then with some dysfunction, if you see the growth plate, then there's still hope. However, if it's completely closed, it's irreversible, right? There's no need to wait because nothing's going to happen. Okay, so this is our friend with a meningococcal infection as a neonate. And the MRI that was obtained on this patient, a GRE, 3D GRE sequence, so you can reformat into the other plane. We see the dark cartilage, the bright cartilage right here going up, and then it's receding, and then it's completely gone. So what we usually do is we take a axial plane, the best axial plane possible through the growth plate. So we got image that look like this. We draw a little region of interest around the area where it's completely closed, right? This is bright cartilage, this is bone. And then we draw it around the entire growth plate and we figure out a percentage. So in your report for these, what the surgeons are looking for is it reversible or no? So in this case, it's not, right? There's no growth plate, it's completely bony bridged. And where is it located? Is it eccentric or centrally located? For this case, it's eccentric, and there's only one location. And then it involves about 36% of the growth plane. So these, because they're peripheral, and under 50% of the physis, they can undergo bridge resection. And in this young child who's only 5, right, still have another half a decade to a decade of growth, you want that limb to grow. And so they would attempt to go in and resect that bridge. For anyone who's who has more than 2 years of growth and more than 2 centimeters of growth, which this patient definitely qualified. In contrast, this is a companion case of a 4-year-old male with incidental transphyseal bridge right here. And remember, these MRI images are 3 millimeter, right? So this is pretty small, but probably about 3 millimeter or so. It's causing a lot of edema because it's causing focal rigidity in that area. The surgeon did not believe us, so still wanted the CT, and we have a nice CT showing that this area is mineralized and therefore is bone. So is it reversible? No, it's bone, right? It's centrally located in contrast to our other case, and it's a focal little punctate area, but it probably only involves less than 5% of the growth plate. So what would you do here? So these are information you need to put in your report, and these patients are typically non-surgical. So this kid is young, right? You don't want to go muck around his normal physis. So usually small physes, small bridges, there's enough force from the normal physis around it that it can actually pull apart those small ones, theoretically. The central ones, like this one, because you have to get through a lot of normal growth plate in order to get to that little tiny bit. So you may be sacrificing the other normal growth plate in order to reach this one. And then not in this case, but in other patients, if they're near skeletal maturity, there's not going to be much time to generate that angulation deformity or the shortening or the growth disturbance. This is to be distinguished from FOP, which is focal periphyseal edema, which occurs at the site of normal physiologic physeal closure, which in this case in the knee is centrally for the tibia and the femur, and the tibia precedes the femur by about half a year or so. And this is usually a diagnosis of exclusion, but these can be symptomatic. So if you don't see anything else and you see a lot of edema, that can be painful to bring the patient to get the MRI. For this particular patient and for this example, you can see that there's a little bit of edema here, right, on the fluid sensitive image. And you can see the growth plate is blurring and getting smaller. You can't really see it as well, not as bright as the peripheral. And then on the T1 or the fat image, you can see that there is a little corresponding lower signal intensity. This patient actually does not have symptom, was just coming in for routine follow-up of his trochlear OCD. So lastly is the deformity. How bad is a deformity that you actually need to do something? So here is a patient who has multiple hereditary acidosis. Sorry. And there is, you can see that there is ulnar negative variance, right? And then the distal radial ulnar joint, which you can kind of imagine here is being pulled open, probably tethered a little bit as well. And so for this one, you know, you have to concern about whether if the growth is affected eccentrically or focal, it can cause angulation deformity. If it's diffuse, it can cause shortening as seen in this case in the ulna. And then it can cause joint tethering as shown here. So the question is the patient skeletally immature? And yes, the patient is skeletally immature. So then you can actually do guided growth in these patients. So guided growth or hemiepiphysiodesis is actually meaning that you sacrifice the normal side in order for the abnormal side to catch up. For the upper extremity, no one cares if it's a little bit shorter on one side than the other, right? But in the lower extremity, it's really important. So in the lower extremity, if you do it on that one side, so for example, the proximal tibia, in order for, I'm sorry, the one side of the tibia, in order for it to not angulate, then you actually have to do it on the contralateral knee as well. So these are typically for cases where the involvement, the deformity involves more than half of the physis. It's multifocal. There's no way for them to go in and resect everything. And then also peripheral, where even if you muck around and try to release that angulation will still persist because just by going in there, you have violated that endochondral ossification. And it's not going to be as happy in pushing new bone forward. So this is the same patient. You can see we sacrifice the distal radius so that it slows down in its growth, and you can see that the ulna now has caught up. This is a different patient with a Salter's type 1 injury of the distal femur. You can see that it's white and irregular. And then 1 year later, the MRI is already showing us that the growth plate looks really sick and that there is bony bridging right here. So unfortunately, the watchful waiting did not work. We waited another 4 years. And so the growth plate actually completely closed and the patient underwent osteotomy. So osteotomy is typically reserved for patients who have more than 2 centimeters of limb discrepancy. And note that this is in the lower extremity, right, weight bearing extremity, where you really do want to be relatively symmetric in length for walking. More than 20 degrees of angulation and patients who have minimal to no growth. Even if you sit there, it's not going to do anything because there's no more growth left. So going back to our index case and wrapping up our presentation, the 2-year-old adopted boy who presented with varus alignment, we have the MRI findings here. You can see that the ossification center is sick, it's smaller, it's not ossified, and then the growth is also asymmetric. This is actually the receded growth plate just because it's not pushing out as much. This is normal, so it continues to grow, but this is abnormal, so it's dragging its feet and not pushing the bone forward. You can see there's a relative abundance of cartilage here, right? If it ossifies, potentially the alignment may actually not be bad. And what's really important for this particular case is that the growth plate is still there. And you want to be able to identify that growth plate kind of throughout. Make sure you don't see any tethering or any bar, because this one may continue to grow. And what you need is another time point. So now you have one time point. You need another 6-month or 1 year follow-up just to see how much and calculate the ratio of growth between the side to determine how much angulation deformity and for them to plan how much rotation they need to plan in for the surgery. So for this particular case, I know I kind of jumped the line a little bit. It's definitely not closed, right? Like our case. And it's not closed here for indirect epiphyseal injury. And it's definitely not reversible like our kind of the sports injury here. So it's actually this indirect injury in this patient, because he's so young, can benefit from guided growth once we know the trajectory of growth from side to side. So as to summarize, normal endochondral ossification depends on the intact nourishing blood vessels from the epiphysis, the zonal arrangement of the physis, and then the non-communicating vessels from the metaphysis to really starve these chondrocytes to die, unfortunately. And this is what we call the growth plate complex. So we're not looking just at the growth plate, but we're actually looking at structures adjacent to the growth plate. Deformity pattern can reveal clues on what was initially predominantly injured. So we have this case where the thicker growth plate suggests it's a metaphyseal-based injury. The focal disruption, focal bar, suggests it's more of a direct injury to the physis. And then this kind of receded growth plate is more suggestive of an epiphyseal injury. Treatment depends on anatomic location, anticipated growth, and severity of the deformity. The presence and absence of the open physis, and that's what you need to do on your MRI, dictates the growth potential and guides the treatment. Treatment includes rest, watchful waiting, guided growth, bar resection, and osteotomy. And depending on the left, we have the growth plate is still there, so therefore you can wait and watch. Versus on the right, it's already hopeless, so they actually have to go through bigger surgery. Thank you so much, and that's my entire presentation.
Thank you so much. That was amazing. Really took us back to the pathophysiology, and I now realize how little I actually did know about the physis after your talk. So that was really awesome for me. Thank you so much. Okay, so now we're going to open it up to questions, and we have the chat box here for people to comment, and then we'll try to answer some of these questions. So we have a question here. Can we use ultrasound to measure growth plate, especially to prevent dysfunctional growth plate? From Samira Shah.
Awesome. That's a great question. I'm a very big proponent of ultrasound by default due to my pediatric training. So So yes, ultrasound is very helpful. Unfortunately, ultrasound does not penetrate deep enough, and especially if you have the bony surface of the metaphysis and the growing secondary ossification center, you may not be able to measure in much deeper than the surface. So I think it's almost analogous to looking for a meniscal tear in the knee with ultrasound. I think if it's really abnormal on the surface, you can definitely tell. But if it's deeper, I think it's hard to get that comprehensive picture. But yeah, no, we have definitely thought about that. Thank you so much for the question.
Well, and I had a question. I think you may have already answered the gymnast wrist and the little league shoulder with the physeal widening and the thickening. So is that because of the failure of apoptosis of that last line of the growth plate? Is that why the chondrocytes kind of stack up?
Yeah, exactly. So the metaphysis has to be intact in order to remove the dead chondrocytes. So even though the growth plate looks thicker, it may not actually be healthier, and it
Right.
structurally may actually be weaker. So that's why usually for these athletes, when they start having these widening growth plates, we really want to shut them down in order for it to for the body to catch up.
Awesome. Okay, we have another question. For vascular malformations over a GP, can ER use ultrasound as it's difficult in India to convince a patient, a child, for surgery?
I
Exactly
will.
question, but
I would try to answer. I think ultrasound is the ultrasound and MR provides complementary information for vascular malformation. We find it very helpful to look for arteriovenous Doppler signal. The only concern we have with ultrasound is if it looks like it has a deeper component, it's transspatial, you may not be able to see everything. And so that's why we always complement with MRI. And with MRI, sometimes we just don't do that, arteriovenous phase as well. And so we do rely on the ultrasound. So I think it is complementary. It is helpful. It's something that we do on a regular basis.
yeah, and to see inside of a bone, you really need MRI. Any role for ultrasound elastography or for the growth plate?
I think I love quantitative imaging, like T2 maps and UTE, quantitative UTE. Ultrasound elastography, I think, would be very helpful. The only thing is, I think the values are very variable between vendors, and depending on how much surface pressure you apply. I think in the setting of the liver, where you get biopsy and pathology correlation, it's very helpful to have that gold standard. Unfortunately, in the musculoskeletal system, I think we probably have other adult MSK radiologists who are much better at answering this. But in the peds, we hardly ever take tissue. And so it's hard to get that reference standard to really figure out what you're measuring has some kind of value, some kind of correlation to disease. We do get a group of patients who have mucopolysaccharidosis, and we do have a clinic, and they come for their clinic appointment, and it's something that we're exploring. But right now, even for those patients, it's not routinely that they get muscle biopsy or tissue biopsy for us to correlate our values to know. So, but yeah, definitely something would be very interesting in the future.
And then we have another question from Lance Williams. Do you see periphyseal edema in a significant percentage of patients being scanned for other reasons, like the case that you showed? I feel like this is common. When to question if this could be symptomatic. I think, are you referring to the FOP zone? Maybe what the question is referring to.
Yeah, so I think the initial paper actually had a few cases that look a little bit scary. I think we have backed off a little bit, mainly for these, you're basically looking at sites where it has slightly earlier closure, where it induces a little rigidity to the growth plate, right? There is less of a cushioning effect because cartilage is 70% water. So when it's not in the typical location where you expect for early physeal closure, I do get concerned, and I do like to get a nice T1 image, because sometimes with the axial loading, and kids do weird things, and occasionally you have microtubercular impaction injury right adjacent to physis, and that's something that I don't want to miss. For kids who are sick, chronic disease, they can have hypertrophy, red marrow hyperplasia, and so therefore that area could be a little bit bright, and sometimes it can be a little patchy. So I do rely on my T1 to make that determination. Is it really real, that what I'm seeing? Because a fluid sensitive image occasionally can look very, very prominent and very like in your face that you have to talk about it. So the other thing to consider, and if you have a wonderful MR tech, is to ask them at the end of the scan, if they have 5 minutes to spare, is to switch the coil to the contralateral side and get you one plane to see if that's consistent to the other side. So if they are closing, they're usually relatively symmetric from side to side, with the exception of ischiopupus and chondrosis. So.
Great, thanks. And then another question about apophyseal injuries. Can you use ultrasound? Yeah. Again, yeah, I don't know how good it is to see deep inside the bone with ultrasound, but I mean, if theoretically, if you had an avulsion, you could see the tendon attachment to an apophysis, an ossicle, maybe.
Yeah, no, I think it's you don't know till you look. So I usually tell the clinician we could look and we could be as good as we can to the contralateral side to show asymmetry. If there is some regional edema, Doppler signal, that will be very helpful as well. So I think induration of the surrounding tissues, more the secondary signs, will probably be more for us to be more definitive, kind of these softer calls. In combination with some bony irregularity. And then again, I think radiograph is underemphasized. I'm so surprised that at least once a week I get a knee MR with no radiographs. And you're like, where's the radiographs? So radiograph definitely help us to complement the ultrasound, just to be a little bit more definitive, so they're not running back and forth with a follow-up ultrasound.
Good. Do you have any experience in imaging children on hormone blockers, and what are the findings?
What hormone blockers are you thinking? I don't know.
Yeah, I mean, I think that we do sometimes see, we didn't go into this necessarily, but changes in the growth plate with some medications, like for example, like at least for us, like in our CRMO patients that might be on bisphosphonate, sometimes we'll see kind of like thickening of the growth plate or kind of band-like signal for those patients. Trying to think what other, anything that affects the growth plate, you might see, growth rest lines and things like that, but.
I think Dr. Diego Jaramillo, who is my mentor in Pediatric MSK, who's wonderful. I know he is looking at using DTI and looking at the using that anatomy of the collagen columns to see the length of those and the density, to look at patients who underwent radiation for chemotherapy due to their cancer, to help to predict how much residual growth. And now that has extended to looking at just normal patients and predicting when they will actually close, just because the hand bone age may be lagging behind by half a year to a year. So I think, thank you so much, all of you guys, for all the wonderful questions. Thank you, Jonathan, for the great introduction. So if I know you guys, I'm super excited that you guys actually spent the whole hour with us. If you guys are ever interested in Peds MSK, I know Jonathan and myself, we're very proponents of Peds MSK. It is very unique. We don't see much OA, but we see a ton of other weird stuff in the younger population, and they're always a little head scratcher. And it's really fun to share cases. I have shared cases with Jonathan as well. You know, between kind of some of us across the country. So feel free to reach out to us if you have questions about career, about lifestyle, about, you know, I don't know, academics, research, private practice, why we're doing what we're doing, what makes us get up in the morning. Yeah, no, I think we're very happy. The pediatric orthopedic surgeons are amazing. They're much nicer than adult orthopedic surgeons, so sorry. And I really enjoy learning from them. I think a lot of what I have learned in the last half a decade is from them pushing me a little bit farther and correcting what I have incorrectly dictated in my reports. So,
and you guys can do 2 fellowships, Peds and then MSK, or you could theoretically do like a Peds mini fellowship and then MSK, or an MSK mini fellowship and then Peds. So there's different ways to get to where we are, in case you guys are wondering. But when you land in Peds MSK, it really is awesome. So. Okay, well, I guess that will conclude our session. Thank you, everyone, and thank you, Dr. Nguyen. And any questions, just email us. And yeah, thank you to the SSR and all the staff and everyone, and have a great evening.